person's MRI. This MRI demonstrates dissemination in time and space. So you have a new lesion, this is something that's active, and then you have old lesions that aren't enhancing in other places. So if somebody presents with one clinical attack in a brain MRI like this, you have demonstrated dissemination in time and space, and you can diagnose somebody with multiple sclerosis. The other way to do it is with CSF testing. So if they have positive oligoclonal bands in their CSF, that counts as dissemination in time as well. This is not to be confused with this entity, neuromyelitis optica. This is a much more rare form of a CNS demyelinating disease, but it's much more severe. It's typically associated with one of two antibodies, aquaporin 4 antibodies or myelin oligodendrocyte glycoprotein antibodies. There's a few clinical syndromes that should kind of tip you off to this. One of them being what this picture on the right is demonstrating, and this is longitudinally extensive transverse myelitis. So this is transverse myelitis that's extending beyond 2 vertebral segments. I mean, if you count 1, 2, 3, 4, 5, 6, this person probably has transverse myelitis that involves 6 or 7 vertebral segments. So transverse myelitis is a clue. This is a patient who presents with an acute medullary syndrome. So you have a lot of aquaporin 4 receptors in the area postrema, and so it's common for NMO to attack this area. And so sometimes patients will just present with intractable nausea and vomiting. Another one being this diencephalic syndrome. So you can see on the picture on the left, a lot of thalamic, hypothalamic, mammillary body involvement. And these patients might present with rather vague signs. They might have hypophagia, hypersomnia. They might not have a lot of focal findings, and there'll probably be changes in their level of arousal. And then severe bilateral optic neuritis should be the other one that maybe clues you off to this is not kind of your bread and butter typical multiple sclerosis. A lot of medications have been approved since 2010, and actually even more since I updated this slide. This could be a lecture in and of itself. There's injectable therapies, oral therapies, and infusion medications. The idea or the goal behind all these medications is that it reduces inflammatory activity, so reduces new lesions popping up on MRI, and kind of reduces the clinical activity, so reduces clinical relapse. There's a lot of variability in risk profile and efficacy, and the symptoms that patients already have, if they have residual spasticity from an attack, none of these medications are going to treat any of those residual symptoms. And the benefit on long-term disability isn't quite as clear, and they're all incredibly, incredibly costly. Okay, so case number 9, a 58-year-old man reports to your clinic with a tremor. It's increased for the past 5 years. He notices it when holding a cup of coffee and improves after drinking a glass of wine. He now tends to imbibe liberally. There are his medications there. Family history, notable for other family members with tremor. And then on his physical exam, he has a relatively high frequency tremor with outstretched arms. And then you can see his Archimedes spiral. So with action, you can kind of see evidence of his tremor as well. So the best diagnosis